أفلح من صلى على محمد وآل محمد اللهم صل على محمد وآل محمد وعجل فرجهم. Bismillah ar-Rahman ar-Rahim. Thank you very much for inviting me to speak today. I thought it would be useful to go through and cover these two topics because they can be quite common, and it's useful just to have an awareness of them. Speaking to someone here a few weeks ago, they mentioned that actually a few members of the community have already had certain experiences with this, and I thought it would be quite useful just to go through because, as I said, it highlights some common things. So what I wanted to go through today is just talk about prostate cancer and the patient journey a little bit in terms of, first of all, background of the actual disease itself. There's quite a controversial topic in terms of the blood test, PSA blood test, that can sometimes raise a few questions, so it's useful to go through that. And what to expect in terms of further investigations and also management. And then I'd do the same in terms of bladder cancer as well. So, in terms of what is prostate cancer, so as with any cancer, it's going to be an abnormal bunch of cells that grow in an uncontrollable way. Now, the thing with prostate cancer is that actually, based on autopsy, so post-mortems after someone has passed away and they check the prostate, there are a lot of abnormal cells in there. So the lesson from that is that if men all live long enough, we're going to have some form of prostate cancer anyway. But the question is that going to cause a problem? Is it something that we need to worry about? Or is it something that it's there in the background, we don't necessarily need to be concerned? And that's where it becomes a bit difficult because it's, as I said, it's sometimes difficult to draw the line of, is it something we need to do something about, or can we just leave it in the background? And if it is there and it's growing and it's spreading quickly, then that's something we can do something about. So, just some facts and figures. Who is more likely to get prostate cancer from the pictures? Any guesses? All of them. Okay, fair enough. Currently, in the picture, who is more likely to get it? Why is Trump more likely to get it? Because? Because that's one reason. That's like du'as and stuff. That's separate. That's between you and Allah subhanahu wa ta'ala. It's because he's older. So older men, generally older men over the age of 50 are more likely to, it's not a disease or a cancer that affects younger people, mainly over 50. And it's also a cancer which affects more Afro-Caribbean men more than Caucasian men. And we haven't quite figured out why. In the UK, 1 in 8 men will actually get prostate cancer in their lifetime. As I mentioned, it mainly occurs over the age of 50. You're 2.5 times more likely to develop prostate cancer if your father or your brother has had prostate cancer as well. So it's something to be aware of. It can have a family trait to it. Even greater if the father was diagnosed under the age of 60. So that's something to be aware of. So if you are over the age of 45 and you have a relative who has been diagnosed with prostate cancer, then it's always worth just going along to the GP having a discussion. There are a few things you can't change. You can't change your age, your ethnicity, your family history, but you can actually control your weight. And diet, weight, being overweight can actually increase the risk of being diagnosed with prostate cancer, more so than just kind of being of a normal weight or a normal BMI, and it will be more of an aggressive disease, i.e. it's more likely to spread quickly if you're overweight. So again, another reason to keep trim or slim. So signs and symptoms. It's variable, and it depends on if the actual cancer is just within the prostate, if it's spread outside the prostate. And they're fairly non-specific. There are certain urinary symptoms which you can get which are not specific to prostate cancer. They can happen as men get older. It's not an unusual thing. Things like difficulty passing urine, weak flow, getting up in the middle of the night, increased frequency. These are all things that can happen with age, but then they can also be a sign that maybe something is going on. The other thing to mention is if it has spread beyond the prostate, you can get other signs. For example, hip pain, back pain, weight loss. You can also get blood in the urine as well. That's something to consider. Again, these things can be down to other things. It's not just exclusive to prostate cancer. So, there are a few things we can do before you come to someone like me. the GP will do a few tests to rule things out, i.e. infection. You can get blood in the urine from an infection. You can have difficulty passing urine because your prostate is getting enlarged because of age. That's, that happens. The blood test is something that the GP can do, and there are certain guidelines about when to do it and who can have one. And then if there is an issue, then you'll get referred in. The way it works in the UK is that you're referred in under a 2-week wait pathway. So you see a specialist within 2 weeks of being referred, and you have treatment, or you have investigations in a certain time frame as well, within a month, for example. There are certain time frames that are audited and, in every department. So if there is a concern, things can move fairly quickly. When you come to a specialist, then we take everything into account. We take what the blood test was, the PSA blood test, the risk of actual prostate cancer is any family history, your general health as well. And if needs be, we can start looking into other things. For example, an MRI scan, and if needed, a biopsy. These are things that we can do in terms of actually diagnosing the prostate cancer. So the blood test. So prostate-specific antigen, it's a protein that is made by the prostate. It's normally present in low levels in the blood, and it can increase with age. So your normal reference level depends on your age. And there are kind of national guidelines which say that if you're this age, this is what it should be. And if it's above it, then we may need to do something about it. So no GPs can answer this, but who actually, can I get a blood test? Can I get a PSA blood test? The young gentleman, if you go to the GP and you say, I want a PSA test, are you likely to get the GP to do it? Because, why not? Cost is one thing, yeah, and welcome to the NHS. Age is another thing. So if I go to the GP and say, I want a PSA blood test, maybe I can convince him because I'm a urologist, but maybe not. But the point is, there's no point doing it of a certain age, unless, for example, there's a family history or there's something else that you're worried about. For example, someone was diagnosed fairly young in your age group and you're around that age, then yes. But actually, there's a national screening program where if you're over the age of 50, and having been appropriately counseled by the GP, you have a right to have a blood test. So if the GP says no, and you're over the age of 50, then go to another GP because it's within your right to check. It's about being aware of your own kind of body. And if you think you have if you think you have symptoms and the GP makes note of those symptoms but still doesn't act on it, then you have a right to get the blood test. If you're over the age of 50, not someone like me. Okay? So, advantages, disadvantages. PSA is useful, but it's not very useful in certain circumstances. It helps to pick up cancer before it becomes a problem. That's why it can be useful. And regular tests can be useful to actually monitor if something is going on. For example, if someone has had an operation for the prostate, we can measure the PSA level, and if it starts to rise, then that's a sign that maybe we haven't taken all of the prostate out, or there's something else we've missed. Disadvantages. If you have a raised PSA, as I said, it's not exclusively related to cancer. If you're riding a bike for 50 miles and then you have a PSA blood test the next day, it's going to be raised. If you do any vigorous exercise, it's going to be raised. There are certain things that can raise it other than prostate cancer, so it's not a be-all and end-all, okay? Usually when you have it done, then it's useful to think about the circumstances around the time that you had the blood test. As I said, did you go cycling for 50 miles beforehand? The other thing to remember is that with the blood test, it can lead down a pathway in terms of having tests, investigations, and treatment, all of which have side effects. So it's about asking yourself, do you want those side effects? Or if you were to have them, are you prepared for those side effects? The other thing is that can actually miss cancer. So 1 in 7 men with a normal PSA can have prostate cancer. 1 in 50 actually can have quite an aggressive prostate cancer. So it's not, if your level is normal, then that's it. It's completely ruled out. There is a very, very small possibility that it may be missing something. Okay. So before you have one, I'm not saying go straight away if you're over the age of 50, go and have one. It's about answering the following questions. Do you actually have an increased risk or not? If your blood level was normal, are you going to be reassured by that fact? Are you going to say, that's it, khalas, I don't need to worry? If it's raised, what would you do about it? Would you say, okay, that's it, I'm going to go and write my will and that's the end of the story? Or do you say, actually, I'd like to find out a bit more? If you're diagnosed with a slow-growing prostate cancer, and it might not cause any problems. Are you happy to live with that? Do you want any treatment that may cause side effects? So there's a couple of things to answer, and this is why it's worth sitting down with the GP and actually going through and seeing, do you actually want something done or not? Okay. Now there's a couple of cancers within the UK which have a national screening program. For example, bowel cancer, cervical cancer, breast cancer, all of these things have, a screening program. But the reason prostate cancer doesn't is because we don't have a specific test which is useful enough for a screening. We only have the PSA blood test. We don't want to do an MRI on everyone because it's an expensive test. We don't want to do biopsies because they have their own side effects. So the PSA is useful, but it has its limitations, as I mentioned before. But as I mentioned, men over the age of 50 can have a PSA on the NHS as long as they've had a proper discussion. Okay. So, mentioned earlier, in terms of a raised PSA, it can be down to other things. Medicines can cause it, a catheter can cause it as well. So, if you have a raised PSA blood test, usually the next step is you're referred into hospital, and the urologist will ask you a couple of questions in terms of your general health, etc. The next step, usually, before a prostate biopsy actually, the current gold standard, including Norfolk Park and Central Middlesex, is an MRI scan. So an MRI scan would be useful because it highlights any suspicious areas that we need to biopsy. And the useful thing about that is it's non-invasive, so the only side effect is you're in an enclosed space and it takes about an hour. But other than that, we're not putting any needles in, there's no injections. You do actually have contrast within it, but the contrast that they use, there's not really any side effects. Very rarely you can actually have an allergy to it, but if you haven't had it, if you've had previous scans and you haven't had any allergies, it's fine. In terms of the biopsy itself, the whole point is you take some small pieces of tissue, you can have a look at it under the microscope and actually determine properly, is this a cancer or not? Even the biopsy itself has its limitations. Maybe the target, the piece of tissue that was taken, missed the actual small area of cancer. So you can have a normal biopsy, but then that might be because the actual area targeted was not normal. Was normal, but it kind of missed the area. But actually, the whole point of doing the MRI now, at least with transperineal biopsy, it's much more targeted. So the likelihood of actually missing a cancer on that is very, very small. So there's a few steps that we've taken just to try and make it as accurate as possible, because it's not easy. You don't want to, at the end of all of this, have something that isn't picked up and then later find out actually there was something there. So there's a few things we can do. Once all of this information is collated, there's a specialist meeting that every case of prostate cancer is discussed in. And this is a meeting made up of urology doctors, of radiology doctors, of cancer doctors, so oncology specialists. And there's a plan that is made, and you're usually seen in clinic very soon afterwards with the options. And it depends on all of this information in terms of what the options are. So the types of prostate cancer, it can be localized, so just within the prostate. It can be locally advanced, so it's just spread just outside the prostate, or it can be advanced. It's spread to other parts of the body, for example, the bones. And it also depends on how risky the actual cancer it is. If it's a very low risk, then maybe the better option is just to sit tight and keep an eye on things. If it's high risk, it may be better to kind of obviously get on with things in terms of treatment. And all of that information is collated and a proper discussion is had in the hospital. So localized prostate cancer, there's a few monitoring options, as I said. Some very odd terminology in the sense of they both mean monitoring. Active surveillance is a term that you may hear. It essentially means it's suitable for localized cancer. So it's just within the prostate. You have regular tests, and it's usually meant for men who actually want the treatment and decide to, actually kind of, I guess, want to take the risk of treatment, and the aim is to cure the cancer if treatment is done. The flip side to that is watchful waiting, where the treatment aim is not to necessarily cure the cancer, but to control the symptoms in terms of other side effects, etc. So there's a slightly different aim. And it depends on, again, the type of cancer that is diagnosed and the other kind of history alongside it. And these are some of the treatment options in terms of locally advanced cancer. So usually radiotherapy, hormone therapy, surgery with some radiotherapy. Again, depends on the actual case itself. And then advanced cancer is slightly different. There's clinical trials involved, radiotherapy maybe to control symptoms, etc. I don't know if anyone saw recently this week, they mentioned a new drug. It says revolutionary. It's actually been around for a couple of years. It's been used for breast cancer beforehand. But essentially, this is a treatment drug that is used for, as I said previously, breast cancer. It's specifically with men with certain genes or faulty genes, because there's a link between faulty genes and actually, as I mentioned, abnormal cells that grow, and as a result, they can cause cancer. So if you have a certain genetic profile, this drug may be useful. The actual data itself, it delays cancer progression by 4 months. So it's small steps, but 4 months can mean a lot. If the cancer is advanced, then you want to spend as much time as possible with loved ones. So 4 months can be a long time. And so this has only recently been approved kind of for use within the NHS, but it's so for a very small number of patients, but significant if that's you. So, any questions so far about that?
You haven't mentioned ultrasound. I understand that also.
Yes. So ultrasound is used for the biopsies, not necessarily for the diagnosis.
What about liquid biopsy?
Liquid biopsy?
I'm sure that's being debated in conferences and so on.
Liquid biopsy I haven't heard of. There's transparent, so template biopsy is one thing. Liquid biopsy I haven't heard of. I don't know. The trouble with this is that they're going to be fairly small. And there are lots of treatments. I mean, I didn't want to go into too much detail, but there's lots of treatments. There's something called high-frequency ultrasound kind of treatment, but that's only really for clinical trials, only in 1 or 2 centres across the UK. And the long-term data isn't there to support it being used for everyone. The test that I've mentioned and the pathway that I've mentioned is usually is the mainstay in terms of treatment and kind of diagnosis, which is why I've mentioned it, because I can go into lots of different avenues, but I didn't want to. It's Friday night. I don't want to put everyone to sleep.
The MRI you mentioned, has there got to be a closed one or can it be an open one?
What do you mean? Sorry, the operation.
No. The MRI machines. Some are closed.
MRI. Usually, open MRI is used for gentlemen of a higher BMI. Usually, so it's a weight limit essentially. It doesn't make a difference in terms of diagnostic purposes. No, because the type of I didn't mention it because going through some feedback. But the type of MRI we use is called multiparametric, which essentially means it's not just one kind of scan. It's 4 or 5 different kinds of scan. Each of them are different, what we call weighting to the actual image, and that's all put together and analyzed by the radiologist. And so with those images, they can actually specifically say, yes, this tiny little area is what we need to focus on. And then when it comes to the time for the biopsy, that area is targeted. So that we... Yes, yeah. So the pathway is you are seen in clinic. If an MRI is appropriate, an MRI is booked. It's the gold standard MRI used across the UK. And now actually what's being done is biopsies, which is actually quite new, but under local anesthetic. So rather than risking a whole general anesthetic being put to sleep, you can actually have it done under local anesthetic. Again, with a discussion with the anaesthetist and the urology team. But small things, okay?
Is there a cure or you just remove the prostate?
The cure is to remove the prostate. So it depends on if the cancer is localized to within the prostate. So if it is, then you take out the whole prostate. And the way that's done is most often nowadays is robotically. So rather than, in the old days, you used to have a very large incision, spend weeks on end in bed, get a pneumonia, and, whereas now it's all robotic. So very small incisions are made. It's all robotically assisted, it's called. But the prostate can be removed that way. And usually, after prostatectomies at least, patients are home next day after. Very, very short stay in hospital. That's the mainstay of treatment now.
You mentioned about the side effects. Doing a lot of time you're saying we just monitor the guy and keep an eye on it.
Yeah, so in terms of this active surveillance, so 2 ways of monitoring, either active surveillance, watchful waiting. Active surveillance is if you are, if you have a disease that is localized to the prostate and it's not aggressive, and you don't want to risk any of the side effects right now. So usually it's a case of keeping an eye on, there's a specific schedule which I didn't mention, but for example, you have a repeat blood test at 6 months and 12 months, and then you have an MRI 1 year down the line. And if there is shown to be progression, then the question is asked to the patient again, would you like treatment or not? And so it's a discussion.
What's the side effect
Of what?
of having the treatment?
So it depends on the treatment that you have. With surgery, there's always risks of surgery, infection, bleeding, not removing the whole tissue. So for example, the prostate that's taken out gets sent off to the lab. And what we tend to look for is something called negative margins. So we look right at the edge, and if there's no sign of prostate cancer, we can be fairly sure that we've taken out everything, including the cancer. And that's generally the end of the story. If we send it off to the lab and it shows that there are positive margins, then you need further therapy in the form of radiotherapy to the area, to the prostate cavity that remains. Side effects with everything, it depends on the kind of side effect, it depends on the kind of treatment that you have. So radiotherapy has its own side effects, chemotherapy has its own side effects, surgery has its own side effects.
Does the robot fix it up?
So the robot is not the robot. I should have put a picture in. Essentially, are you aware of keyhole surgery?
Yeah.
So with keyhole surgery, the surgeon is holding the instruments. With robotic surgery, the instruments are docked into the robot, and the surgeon is away from the patient but controlling the robot. So the surgeon itself the robot itself doesn't actually have any control. It's entirely dependent on the surgeon making the moves, making the incisions, etc. So it's not the robot. The robot is only there because it offers better views. Okay, you can imagine down in the pelvis, down here, it's a very tight space, and you can magnify it a great deal. Kind of ultra 4K HD, amazing images, okay? And that's good because the side effects of surgery can be, generally the two main things can be incontinence and effects on, I guess I didn't want to say it, but sexual function that can be affected as well. And the benefit of doing it with a robot is, again, depending on the kind of surgery or where the cancer is, you can spare the nerves that control those functions. And the benefit of doing it with a robot is it's much more accurate, rather than doing it in the olden days in terms of open surgery, not knowing exactly where things are. It just gives a much greater level of detail. And actually, the data from robotic surgery, although it's expensive, yes, but the data is there to support the actual use of it in experienced hands. So it's very useful. So it's here to stay. But the robot itself doesn't do anything. It's controlled. I can't sit there with a remote control controlling everything. But actually, on that, a doctor was in another country. So over Wi-Fi, they did a prostate. I don't know if it's prostate, maybe a nephrectomy. Over Wi-Fi, they did a surgery in India. The surgeon was here. The operation was in India. The robot was in India, over Wi-Fi, and there was only a minimal delay. For example, the surgeon moves. Maybe half a second later, the robot in India moves. So that's the level of technology that there is. In the UK, the robot's in the same room. The surgeon's in the same room. Okay. Any other questions? Yeah.
You mentioned the importance of weight and diet.
Yes.
Is there a causal relationship between certain foods and...
It's not specifically certain foods. It's more weight is a kind of link. And it's not a causative link. It's more of an association. So generally, if you are more overweight, if you are going to get prostate cancer, the type of prostate cancer you get is more aggressive, i.e. it spreads more quickly and needs to be treated more quickly. Otherwise, it will spread. Very, very, very weak evidence. Very weak evidence. Yeah. It's not kind of, there isn't a very kind of significant causative link. The main advice has just been exercise, healthy diet, exercise, as with everything. Okay? Okay, I think this side of the audience are getting very bored. This is prostate cancer's all men. But actually, you guys have to look after them. So if they're ignoring stuff, you need to nag them and say, look, you need to do something about it. That's where you're very useful, because, we ignore things until something bad happens. Okay, so everyone in this room has a bladder, so that's a bit more generic. So bladder cancer, 10th most common cancer in the UK, smaller numbers. So in the UK, maybe 50,000 men are diagnosed with prostate cancer. In the UK, just over 10,000 people are diagnosed with bladder cancer. And the trouble with bladder cancer is it's diagnosed late. The reason is that people may ignore symptoms, they may kind of not necessarily worry about it until it has spread and therefore become more of a problem. And actually, there's a good survival rate if it's caught early enough. So it's something to kind of be aware of, that actually if you start having some symptoms, don't ignore them. Go and see the GP. So everyone knows what the bladder is. It holds the urine, kidneys filter it down, and it expands to about 500 mils. So about a bottle of Coke, and then you need to go. It's variable. Everyone has a slightly different size. Now the actual cancer itself, I don't know how clear is that. Oh, that's not very good, is it? So this diagram essentially shows that the actual cancer itself grows in the lining of the bladder, and there are different types in terms of how deep the cancer goes within the bladder. Generally, two classifications: non-muscle invasive, muscle invasive. Muscle invasive implies that it's deeper within the bladder. Okay, as you can see from yeah, you can see from the diagram. So this one is very superficial, and then as the diagram goes round, it becomes deeper and deeper, and therefore more difficult to remove. So symptoms. It's important to go and see the GP if these things are happening, because it's a case of being properly investigated. The main kind of thing is blood in the urine. So if anyone sees blood in the urine, then that's a warning sign. You have to go and see the GP. The GP will refer you. You'll have some investigations. Even if you're taking things like aspirin or clopidogrel or warfarin, apixaban, those can cause blood in the urine, but actually it's better to get investigated, because once you've had it done, then okay, fine, you know that it's not necessarily a problem. But if these things are happening and you haven't been investigated, please go and see the GP. So, as I mentioned, blood in the urine is the most common symptom. It can also appear as small clots in the urine. That's, again, something to be concerned about. If left long enough, the clots can become very large, and then you essentially get stuck. You're trying to pass urine, but you're unable to, because the clots are blocking off the passage of urine. And that's where you need to come into A&E. With women, it can be slightly difficult, because it's difficult to ascertain in terms of where the actual blood is coming from. But if there's any kind of suspicion or doubt or anything like that, then please go and see the GP. Because it's more common in terms of, again, older women. Non-visible blood, essentially, this is when you go and see the GP and they do a small dipstick test and it shows blood. So if you pass urine, you don't see any blood, but when the GP dips the urine with a little dipstick test, there's blood on the dipstick. Again, that can be down to lots of different things. If it's persistent in the absence of any infection, then that's another reason to be referred into hospital to have some further investigations. If you're having recurrent infections in the waterworks, again, that's another cause, so something that is useful to kind of get checked. The trouble is that, for example, you can have a urine infection, antibiotics cure the problem, everything goes away, and then it comes back again. You're given some more antibiotics, it settles down, and that cycle repeats itself. If that's happening, then that's a warning sign that maybe something else is going on. Again, needs investigating, okay? The other thing to consider as well, hands up in this room if you smoke. Oh, that's very good. Okay, no smoking. So, smoking is a big risk factor for bladder cancer. Also, if you live in Egypt, but that's because of a bacteria. But generally here, if you're a smoker, so it's good that you don't smoke. If you do, quit, because it's not good for your bladder. It's not good for your lungs either. So, what happens when you come into hospital? So, a urine sample is also taken, and there's something called a flexible cystoscopy, which is essentially a very, very small camera that is put inside the water pipe into the bladder, and we have a look. And that allows a proper direct visualization of the actual bladder, and if there's anything suspicious there. If there is something suspicious there, then a discussion is had in terms of what needs to happen next. Generally, it's a case of if it's the first time something like this has happened, it would need to be removed under general anesthetic, so whilst you're asleep. We do the same kind of thing and we'll remove it. At the end of all of this, 1 in 4 patients who have visible blood in the urine will have a bladder cancer. Whereas only 5% of patients who have non-visible blood will have a bladder cancer. So it's small amounts, but significant. 1 in 4 patients, that's a big number. But blood can be caused by other things. For example, you may have a stone. It might just be you have an enlarged prostate, which bleeds. That can also cause blood in the urine. The other investigation to remember, so the actual flexible cystoscopy looks at the bladder only, but bleeding in the urine can come from anywhere. It can come from all the way up in the kidneys. And the way that is assessed depends on if the blood is visible or not visible. If it's visible, you have a CT scan. If it's not visible, you have an ultrasound. That's generally how it works. So we need to look at, as it were, bottom end, top end as well. So these are just some pictures in terms of what bladder cancer looks like when we have a look. Does that remind you of anything? Sea anemones? Does that? So this is essentially what it looks like. The picture on the right is essentially this instrument is used to actually burn the base of the actual tumor and to remove it. And that's done under general anesthetic. You'll be asleep for that, don't worry. Okay. As I mentioned, ultrasound CT. And then rigid cystoscopy is just the one on the right in terms of having a look with the bladder and actually removing the tumor. Again, through cancer, it's about low, intermediate, and high risk. The majority of bladder cancers are low and intermediate risk. And they can be treated fairly kind of quickly and without any significant drastic treatment. And it's a case of coming back again in terms of surveillance. So if there is a small superficial cancer, usually the surveillance is up to 5 years. So you have the camera test maybe 3 months, 6 months, 9 months, once a year, up to 5 years. And if that's clear, then we discharge you back to your GP. So it depends on the actual type of cancer itself. Again, in terms of the actual treatment itself, non-muscle invasive, so fairly low risk. So the actual tumor is resected. There's different therapies, and again, it depends on what kind of cancer you have. So if it's a fairly superficial one, and that's diagnosed once we take out the sample, send it off to the lab, you have what we call intravesical therapy. So basically a small chemical is put into the bladder, left for about an hour, and that's repeated once a week for 6 weeks, and then 6-week break, and then another course. So the idea is that it tries to modify the lining of the bladder to prevent any further growths. But you can still have growths potentially after that, but it drastically reduces the likelihood of that happening. So that's the whole point of that. If it's a high-risk cancer, then, and you know, other factors are considered, then the whole bladder can be removed if needed. And the way that's done is, again, robotic. You can do that robotically. So the middle picture is essentially normal anatomy. Does it say? No, it doesn't have much. So the middle picture is normal anatomy, and then you can either form using a bit of bowel, a small pouch that comes out to the tummy, and that's where the urine collects. You can put a bag over that if the bladder is removed, or you can create a new bladder, and that takes on the role of storing urine and then kind of releasing it. So there's 2 different kinds of operation in that circumstance, if that's needed. Just some references as well. Thank you very much. Any questions? No. Again, more likely to happen, but if you're young and you're smoking 50 a day, then something is going to happen potentially. So age for bladder cancer doesn't necessarily matter. Because you can have blood in the urine at any age. If you see blood, if I go and see blood, I'm going to go and see my GP tomorrow. I'm going to wake them up. I'm going to say, I need to come and see you on Saturday morning, because the concern is that there might be something going on. It might be nothing, but if you're seeing blood, that's not normal, and therefore that needs to be investigated. So it can be any age.
So, be it bladder or prostate, if I am in the unfortunate position that the final conclusion is that you need some sort of surgery, and if Mr. Hassan Kadhim is on holiday, where shall I ask my GP to refer me to? If you were in my position, and you know it's the technical issue to make sure that we get the right surgeon to do the right thing.
The surgeon, if you're being referred locally, there are only going to be a few surgeons that do these operations. In this urology department, there's 10 consultants. Maybe 2 of them do prostatectomies, so removal of the prostate. 1 or 2 of them do cystectomies, removal of the bladder. But the majority of bladder cancer, at least, is way before that. Only a small proportion actually need to have the whole bladder removed. It's only for a very aggressive, very advanced disease. The mainstay of it is a general anesthetic, removing it by kind of burning the tissue away. That gets sent off to the lab, and then we keep an eye on you by doing outpatient investigations. So the outpatient camera test under a local anesthetic. That's generally the mainstay of it. And then if needed, we can give you that therapy within the bladder. So
that's all I was asking. You feel confident about the local urology service. I wouldn't insist on my GP to send me to a London hospital, would I?
No, they're good. There's a good website actually. If you want to compare across the whole of London, I can give you the name of the website. That website has the number of operations that the surgeon has done, both robotically assisted and otherwise, and also complication rates in terms of how long the patient stayed for afterwards, did they need or did they require a blood transfusion after the operation. All of these things are documented and audited in terms of surgeon kind of profile.
Is there a huge variation, or?
No, because it depends on the center. So, for example, Guy's Hospital, I was looking at the data actually, not yesterday, day before. There's a surgeon there who does the most, again, not prostatectomy, cystectomy, but does the most partial nephrectomies. So if there is a kidney cancer, removing only part of the kidney, he's done the most across the UK. For example, so you could potentially be referred to him, but maybe privately. But the local unit here, I think cystectomies aren't necessarily done here. They're done in Charing Cross Hospital. So if that is something that is required, you'd need to go to Charing Cross Hospital. Again, because it's surgeon expertise. The type of surgeons that are doing these operations aren't people who have just started out. The majority of them are bald, for a very good reason, because they're very experienced consultants. They've been consultants for 15, 20 years. The one here who does prostatectomies has done, I think, 150 robotically, or thereabouts. So he's very, very experienced.
So just one final point, as far as post-operative nursing care is concerned, within Norfolk Park or Northwest London, do you feel comfortable with that? Just wearing a hat of a patient.
I can't really comment because I tend to just do the ward round and then disappear. But generally, on the whole, it's not too bad. It also depends on potentially the ward you're on. But generally, for urology, patients are quite happy. Now, I'll give you actually a bit of insight. So before I joined working in Norfolk Park, everyone was a bit, are you sure? On the whole, things have been relatively good. There are, at least from the urology department, from all the way from the consultants to the registrars to the nursing, like clinical nurse specialists, everyone is very kind of keen, switched on board with research, wanting to make a difference in terms of actual patient outcomes. So they're a very switched on bunch, which is good.
Assalamu alaikum.
Alaikum salam.
Thank you for your talk.
That's good.
I was kind of wondering, you've spoken a lot about, like the treatment of these cancers, but with regards to them, do you think that necessarily we take the kind of like the lifestyle elements of it seriously enough in terms of like before any of this appears? And I know your expertise is kind of more like in the surgical side of things.
Yeah.
But you kind of like with the robotic stuff, you have like a future facing like eye on that.
Yeah.
And like we hear a lot about how life expectancies are going up. We're more like well nourished as humans these days. But is it something that goes into a lot of thought for yourself as a doctor treating these patients as to how they've come to the point where they've developed these cancers?
Are you saying in the sense of, I'm trying to understand the question. So you're saying that people are so, as in people are living longer, so they're more likely to get something like this?
Yeah.
Or?
And do you think we necessarily, because it's more prevalent today, the reason we're having this discussion, the reason we're able to talk about this in a community setting, do we take seriously enough the kind of like the elements that go into lifestyles leading up to getting the disease?
I mean, I think there are certain lifestyle elements which you can change, but there are certain things, as I mentioned, that you can't. For example, you can't change your age or your gender or your ethnicity, your family history. These are things you can't change. What you can change is your lifestyle. For example, with bladder cancer, there's a very well-known causative link between smoking and bladder cancer. In terms of, it's very clear-cut, which is why I suggest if you do smoke, then just, it's not worth it. But in terms of other lifestyle choices, as I said, there are some things that you can change. There's some things that you can't. We are seeing, from my point of view, we're seeing more complex patients because patients are living longer. When they come for the operation, if they are suitable to have the operation, they're going to have more medical things going on with them. Maybe a bit of heart problems, maybe a bit of lung problems, and it makes it more complicated. But that's not to say that's just the natural progression across every specialty within the NHS. That's the challenge of patients are becoming older and therefore living longer and therefore developing more. So just because someone is old, they shouldn't be written off as, this patient should not be considered for X, Y, and Z treatment purely based on their age. It's about what kind of 95-year-old they are, if they're 95.
Is it something where as a doctor you kind of say, okay, we accept that a certain amount of people are going to develop something like this, and then we improve the way that we treat things, we improve and develop all the stuff about what happens after, or is it the kind of thing where in your mind you're thinking, oh, if this person had taken much better care of themselves earlier on? No, not
necessarily. With the thing with, as I mentioned, in terms of with bladder cancer, there's a specific link, but prostate cancer, there's not necessarily a link of how people live their lives. It's 1 in 8 men will have prostate cancer. So, and that might be a prostate cancer that never bothers them. They don't even know it's there. Otherwise, it might be actually, it does cause symptoms and they need something doing about it. But in terms of lifestyle effects, it doesn't necessarily...
There's no kind of like relationship that can be told there at the moment.
No. Other than maybe losing a bit of weight. That's always the case.
In terms of surgery, which one would you recommend having the least side effects? Open, robotic, or keyhole? Between the three, which one would you choose?
Generally, laparoscopic surgery, so keyhole surgery, is no longer really done because robotic surgery is much better for these kind of cancers. Laparoscopic surgery is still a thing for other diseases because the robot isn't used for every kind of surgery. It's only used for specific kind of fairly complex surgery. You're not going to have a robot repair a hernia, for example, because that's overkill. That's like saying I'm going to take NASA's space shuttle to work because that's the fastest way of getting to work. It's overkill. In terms of which type of surgery it needs a conversation. So generally, very rarely nowadays is open surgery offered. It's only if the prostate gland is very, very large and trying to do the operation robotically may cause more harm to the patient. But I can't say one is better than the other purely because it's specifically down to each patient. And it's about having that conversation and taking in lots of other factors into play and saying, based on all of this data, the best option for surgery would be this. But in terms of surgery radiotherapy, as much as I would like to say surgery is better, actually the outcome, the data in terms of, life expectancy and so on and so forth, they're fairly similar between surgery and radiotherapy. So I'll give you an example. If the prostate cancer is localized to within the prostate only, at that point, if there's going to be treatment, there's two options. There's surgery and there's radiotherapy. As a surgeon, I would love you to say, yes, I want surgery because it gives me something to do. I still have a job at the end of the day. But actually, the outcomes for both of them are fairly similar. Some patients are completely against the idea of still having the prostate with the prostate cancer in them because they know that that prostate has cancer in it and they want it out. They want surgery. Take it out. Other patients actually say, no, I don't want the side effects of surgery in terms of maybe infection, maybe bleeding, and therefore I'm going to go for radiotherapy. But radiotherapy has its own side effects. It can cause damage to the surrounding structures, not just the prostate. It can cause damage to the bowel, it can cause damage to the bladder. They both have their own ups and downs, which is why it needs a proper discussion between the surgical team and the oncology team, because the surgeon doesn't do the radiotherapy, the surgeon does the surgery. The oncology doctor, the cancer doctor, will offer the radiotherapy, and therefore, usually, in these kind of scenarios, a patient sees the urologist and also sees the oncologist, and therefore has a proper in-depth discussion about the ups and downs of both treatments, and then a decision is made in terms of what the patient would like to do. So I can't say one is better than the other. As much as I would like to, I can't say one is better than the other.
I mean, from the point of view of side effects, I'm talking about.
They both have their own. They both have their own different side effect profiles. Everything in medicine has its own side effects, but it's about, do the benefits outweigh the side effects, or the risks at least. The side effects aren't a given. You're not definitely going to get an infection after surgery, but you're not definitely going to need a blood transfusion. These are all possibilities. But these are all possibilities that need to be considered when you're making a decision about which one to do. And it's about having that discussion properly and going through. So it needs a proper discussion with the patient and with both of them. And then it's about deciding what you want to do. It depends on the cancer. If for example, if it's localized, if you can offer both, and it depends on what the patient wants to do. And it depends on comorbidities as well. For example, are they fit for a general anesthetic or not? And so those other things kind of factor into it as well. But there isn't a specific age cutoff. It's different hospitals, different trusts. So for example, more than the age of 70, then they maybe think, another thing to consider is life expectancy as well. So if you're 85 and you're diagnosed with localized prostate cancer, you probably wouldn't be offered surgery because the risk, you might end up dying from the surgery as a result, which is obviously not something we want to do. And actually, is that cancer going to cause an issue? Which is what I came back to from the original, at the beginning, in the sense of, is it something that is going to cause a lot of aggravation? Because the surgery itself is not side effect free. It has its own side effects and its own risks. And it's about quality of life as well. So all of that is factored in. If the prostate cancer isn't going to cause too much trouble, then it may be better to just leave things as they are and see how things go with some blood tests, monitoring, etc. If it becomes more of an issue, it can be addressed later on down the line. Different ones. So for example, I was working in Chichester, and I think it was 70. 70, they wouldn't usually offer robotic surgery for the prostate cancer because it's about life expectancy as well. But it's variable. Different centers, different. And part of it is based on the experience as well of the surgeons. So the center down in Chichester, there's 4 surgeons, and between them, they do maybe 500 cases a year. So it's quite a large volume center, as it were. They see a lot of patients. So they know which one is actually going to benefit from the surgery, which one isn't. But it's about having that discussion.
There's a lot of problems with saying within a day you go home. That's it. It's done.
Yes, but then you might end up needing a blood transfusion, you might end up getting infection, you might get sepsis, you might end up in ITU for a week. So it's variable. Everything is done to try and prevent all of these things, but at the end of the day, at some point, with both procedures, with both treatments, there's going to be a consent form that needs signing. And it's about whether you would like to take on that risk or not. Are you prepared to take on the risk of infection, bleeding?
That's any surgery.
Exactly, it's with any surgery. So maybe not. Maybe you're the unlucky one that does get the infection. Maybe not. But all of these things, for example, every operation, you're going to have some antibiotics before the operation. So there are certain measures, but it's about accepting that side effect profile. As I said, some people kind of hate the idea of having a prostate cancer still there and they want it taken out. You go through all of the side effects or the risks and they say, I don't care, take it out. Other patients actually say, no, you know what? I don't want to go through all of that. Give me the radiotherapy. I'll take my chances. And the radiotherapy can be curative. The whole point of it is that it's curative if it's localized within the actual prostate. The flip side to that, with radiotherapy, you're not sending off the prostate to be analyzed. So there may still be some residual cells left within the prostate. With surgery, you're taking out the piece of tissue that you want to send off to the lab, and that gets sent off to the lab. So it's variable. Depends on what you would like to do.
I guess there's one other difference is that following radiotherapy, if you then have recurrence,
surgery becomes much more difficult.
whereas vice versa, it's
Yeah, you can have the surgery, and if there's still a little bit left, you can have radiotherapy. If you have the radiotherapy first, doing surgery in a pelvis that has had radiotherapy to it, everything is stuck to everything else. And so the actual surgery becomes much more challenging. And so some surgeons don't offer that because they're not experienced enough, they're not confident enough to say, if I go in there and have a look, I might mess everything up and might end up terrible. But some surgeons are willing to take that risk because they see more complex patients. So maybe some surgeons will offer that surgery after radiotherapy, but some surgeons won't. Again, depends. Any other questions?
what is the mortality from this to
For
numbers dying
for prostate cancer?
from prostate cancer?
After what? So it depends. It depends on if the cancer is high grade for prostate cancer, and it's untreated, then it can be fairly quick. Again, I'm not going to be able to put any figures on it, but kind of mortality is quite high, which is why we want to try and, because the trouble is it will spread, and then you'll get side effects from the spread of disease. An example can be with the prostate gland, it can spread to bones, and the most common place it spreads to is the spinal cord, or the spinal cord. So you end up having the nerves that control the legs and the kind of bowel function, urinary function being affected. So the reason we treat it is because we want to avoid all of these things. That's the reason we take out the cancer if we can. In terms of mortality as well, it's with
Numbers dying of these things.
yeah.
Like we know, for example, heart disease kills.
So there's a man every 45 minutes. I read somewhere every 45 minutes a man dies from prostate cancer. So that's the kind of figure in terms of prostate cancer. I don't have the same kind of thing for bladder cancer, but bladder cancer, the trouble with it is that it's diagnosed late, which means that the stage that it has reached means that you can't necessarily be offered any curative treatment for it. And so the only thing left is to control the symptoms in terms of pain, in terms of bleeding, etc. That's the difference between prostate cancer and bladder cancer. And there's much more awareness about prostate cancer rather than bladder cancer, purely because a lot of celebrities have been diagnosed with prostate cancer. They've had their treatment for it, and now they are advertising that fact, and therefore there's much more awareness about prostate cancer rather than bladder cancer. But actually, bladder cancer, because it's diagnosed late, actually has a higher mortality because it's diagnosed late, which is why I'm stressing. Go and see the GP if you see any blood.
Thank you very much. I think we'll end there. Salawat.
اللهم صل على محمد وآل محمد.
If you have any further questions, I'm sure Hassan is around. Please.
Don't give my address.